Thank you, Dr. Ghanem and Dr. Kathari, for letting me speak today. I hope I can answer this question. I find it a little fascinating myself. And so I just have a disclosure of a research grant with Teleflex, which will not be part of this talk. So when you look at the original publication by Dr. Rutledge in 2001, I found it fascinating that Table 1 actually listed about 25 features of what he considered an ideal weight loss operation. And so I thought we could kind of walk through this and see if the current studies out there looking at OAGB fit any of these features and how ultimately we can decide whether this is a safe procedure and what gap it may fill. So when you consider the OAGB, the initial surgery was a combination of the Billroth and the loop anastomosis by Mason. The loop gastric bypass, though, was clearly, the anastomosis was at the cardia, and so that bile reflux was able to reflux into the esophagus, causing significant complications, where the Billroth 2, the anastomosis, is much closer, as we all know, down by the antrum and the body. So this initial description of the OAGB included a much longer tubular structure based on the lesser curve with that same loop anastomosis. And so it was obviously documented as easy to perform and with a very quick, I think the 30 minutes to 20 minutes of operative time. And then this was quickly modified by Dr. Carballo, who created the lateral anastomosis, and then a little bit of the connection, creating the efferent limb at the more proximal position to create flow into the afferent limb. So I think looking back at that Table 1, the 25 different features, yes, so far we've determined that it's safe, minimal trauma from the early studies. There was a short recovery time documented and then noted that it was relatively easy to perform, single anastomosis. What about weight loss? So when you look at weight loss, and I felt we should compare to our current procedures, so looking at the sleeve gastrectomy and then the loop OAGB, this is looking at BMI. This is a study, a randomized controlled trial that looked at patients that had lower BMI, but shows the dramatic and durable weight loss that occurred in patients who had OAGB out to 5 years, and this was statistically significant. The next comparison I found was looking at total weight loss and was able to compare gastric bypass, OAGB, and SATI. And so what we found is that the percentage of weight loss was in between the SATI and the gastric bypass. And then the literature was able to follow the gastric bypass and OAGB out to 10 years. So it's performing in between the SATI and the gastric bypass. So check the box, major weight loss, lasting weight loss. Okay, we're getting there. What about glycemic control? We're bariatric surgeons. We care about treating diabetes and the medical comorbidities that come along with it. We know intestinal bypass has all of the gut hormones that will improve our glycemic control. So this particular study, again, showed outcomes looking at A1C specifically. And so these patients had quite uncontrolled diabetes, so A1C started at 10, dropped down on the loop anastomosis, the OAGB, and then compared to the sleeve. So again, 5 years, hemoglobin A1C is 6, statistically significant. So we're effective in this particular study, more effective than sleeve. This kind of separates out by our type of medication, similar to our Stampede trial, looking at this is the Y-Omega study, looking at remission, whether patients are on medication. A1C doesn't tell us everything, gives us a little bit more data. So 60% of the patients in the OAGB were able to achieve complete remission at 2 years. These numbers are very small, so this was not significant. So I'd say back to that, the number of features of an ideal procedure, verifiable results in the fact that there's better glycemic control. It's an intestinal bypass, so we're going to have good outcomes when we're looking at treating diabetes. But I think this is where things get sticky. A little bit of the, what Dr. DiMaria was alluding to was the lack of kind of a standardized limb length. When going through the literature, I found these previous concepts included measuring the entire bowel length. If the BMI was 50, 50% of the total bowel was bypassed. If it was 40, it was 40%. If the BP limb was measured to equal 50% plus 50 centimeters. You could bypass 40% of total small bowel length. There's a ratio. The common channel could be around 180 to 220. So I think this is where things kind of get a little confusing looking back through the literature, because when you're adding and the bowel lengths are not standardized, and we're kind of drifting into the very short common channel, that's where we have these episodes of vitamin deficiencies, hypobuminemia, and overall poor outcomes. This particular study just shows how the variability in these in the OAGB compared to the gastric bypass. And I do think what the ASMBS did accomplish was the description of the technique with this long 15 to 18 centimeter gastric pouch, again sitting kind of closer to the antrum and that transverse colon, right? A little bit easier to pull the bowel up. The lateral, that Carbero anastomosis, and then the 150 to 200, and the recommendation was 150 centimeters to limit those nutritional deficiencies. So what about GERD and bile reflux, right? This is what we worry about. So comparing studies between gastric bypass, your loop, and SADI, we can see marginal ulcer rates up to about 13% for the gastric bypass, where, with the literature we have, may sit around 5% for the OAGB. Symptomatic bile reflux, and again, I caution, these are single digits, but oftentimes symptomatic bile reflux in a paper will include heartburn and bile and some complaints of intermittent vomiting that's bile tinged. So comparison though, single digits still 3, and then double that for the OAGB. But we do have the complaints with the SADI also. And if you look at the difference, we have the pylorus and then a little cuff of duodenum if you're lucky. Some days you're not. And if you mobilize the right gastric, you've created that pipeline for the SADI. I think some of us have also learned that creating that bringing the afferent limb up creates that flow into the efferent limb a little bit better. So some ways we've been able to technically change, but the amount of reoperations is still low. So I would say minimal retching, vomiting, maybe we failed on that bit. Marginal ulcer, still unclear. But I would say patients that have either hiatal hernia, laxity of the LES, documented reflux, this may not be the best procedure. So complications, Dr. Brown went through in much more detail, but again, this compared gastric bypass, OAGB, and SADI. Where do we fit this? Where's this procedure fit in our options? And look at the early complications versus late. So the early complications, it's single anastomosis, lack of leak. And so those were in between versus late complications of internal hernia and marginal ulcer with a gastric bypass. So still in between the two. So no ICU stay, minimal blood loss. So single versus double anastomosis, this looked at single gastric bypass, double anastomosis gastric bypass versus your single versus double duodenal switch. So like we mentioned before, one loop, you're not cutting the mesentery. So few adhesions, limited internal hernias. We're back to shorter operative times, short recovery times. So there's some boxes that we're checking. There is opportunity for conversion of a sleeve for patients that have insufficient weight loss. There's up to 22% of sleeves that may need some type of revision, and this study showed that sleeves that converted to OAGB had 71% excess weight loss at 2 years, improvement of their comorbidities, and then complications of what we discussed earlier with GERD, leak, and bile reflux. So I would say that we accomplished changing in eating and behavior. And then the tricky part, though, I would say, is that conversion. Some things noted was that the procedure should have malabsorption that's easily managed versus easy to convert. And I would say this can be a little bit tricky. For weight recurrence, no reflux, just transection of the loop is a little straightforward, but for acid reflux, bile reflux, nutritional deficiencies, it becomes quite complicated. So we fill the gap, safe, major weight loss, maybe questionable with some retching and some bile reflux. Malabsorption is still a questionable, I would say, overall difficult decisions that we make and share with our patients. Weight loss would be similar to the gastric bypass, limited complications, can achieve glycemic control, and then maybe the patients that have hiatal hernias may not be ideal, and better to understand the pathology of bile reflux and limit the biliary limit to 150 to prevent deficiencies. Thanks. Sorry, when I divulged.